Welcome to the Integrative Medicine Grand Rounds at the Osher Center for Integrative Medicine at Brigham and Women's Hospital and Harvard Medical School. If you're requesting CME credit, please see our event post on oshercenter.org for email request instructions. And now it's my great pleasure to introduce our Grand Round speaker this morning, Christian Büchel. He's a professor of systems neuroscience and head of the Department of Systems Neuroscience at the University Medical Center of Hamburg in Hamburg-Eppendorf in Germany. Dr. Büchel is a recipient of many honors, including the Leibniz Prize awarded to exceptional scientists for outstanding achievements in research for his groundbreaking characterization of neuronal networks, which play a role in such complex brain processes as learning, memory, speech, fear, and pain. His studies cover a broad range of topics and are notable for their interdisciplinary approach. In his cognitive neuroscientific studies, he showed that functional interaction of the brain's regions are subordinate to higher cognitive processes. His often highly technical research couples cognitive research with basic research in neurobiology to produce findings that are important to clinical practice. And today, Christian will speak to us about the neuronal mechanisms of placebo and nocebo effects. Welcome, Christian, and thanks so much for joining today. Christian, oh, there you go. Are you muted? Yep.
Yeah, sorry. I had to unshare my screen and now I have to share it again because I couldn't unmute with the screen shared. So here we go. Now, I hope you can all hear me. Thanks for the invitation. It's my pleasure to come over to Boston, if it's only virtually, but you've heard all this before and we've all sort of got familiar with Zoom. Now, what I want to do today is I want to split my talk in three parts. First, I'll talk about old stuff and placebo analgesia, and we'll talk a little bit about the mechanisms, the role of endogenous opioids, some of the spinal mechanisms that we revealed, and then also how placebo analgesia might have to do with value of treatment. I'll then go into part of the presentation where I talk about how integration of expectation and sensory input might actually work. We'll talk about some of the acute pain experiments that we've done. We'll then turn to an idea that we had about 6 years ago of Bayesian integration of how expectation and sensory input can be integrated, and the precision of that expectation can also be taken into account. Finally, I will talk about the sort of bad sibling of placebo, the nocebo effect. We'll talk about spinal mechanisms of nocebo in pain. Again, look at the role of value in nocebo, and then show a brand new study that hopefully will get published soon about nocebo effects in respiration. Now, coming to a very simple model of perception is what some of you, hopefully not, have learned somewhere, is that a stimulus is directly linking into a percept with a direct arrow, and that very simple, obviously, model is not correct, because we all know that expectation, not only in placebo or nocebo research, but also in visual perception, plays a huge role, and that this expectation is not sort of standalone and immediate, but can also be sort of shaped by memory, or we like to also call it experience. Now we have the two ingredients, the expectation and the stimulus, and then we have to integrate the two, and then we basically get what we think about is a percept. Now, if you take a very, very simple approach of how integration works in the example of placebo analgesia, here's how it might work. You have a treatment expectation in blue, and that is basically on a VAS scale, so it's a visual analog rating scale of a certain pain expectation. You expect the pain to be at the level of 30. Now, the sensory input that you actually get is of intensity 50. And now by integrating the two, your expectation and what you really get, you might actually meet halfway, and your percept might be sort of a compromise of what you get and what you expect. That's a sort of a simple, in a nutshell, idea of integration, how placebo analgesia might actually work. But bear with me, this is way too simple, and we will show you a refined model of that during the mid part of the talk. But first, I want to show you some of the old results that we acquired in the context of placebo hypoalgesia or analgesia. And by the way, this difference here between what you get and what you perceive, we refer to as the placebo effect. Now, when Ulrike Bingel, who you can see here, was a postdoc in the lab, she did the early studies of placebo analgesia in the lab, where we used a cream and told people that this cream is actually tested for the painless insertion of IV lines in children. So we created an expectation that this cream will limit painful sensations. And this was indeed the case. If we compared this placebo treatment to no treatment, we found a significant reduction of perceived pain, as you can see here, for the placebo treatment. And that was mirrored by a decreased activation in parts of the brain, secondary somatosensory cortex, anterior insula, that we know code the intensity of pain. So these areas basically show if they're highly activated, usually you get high pain. If they're lowly activated, you get little pain. Now, there was also an activation that was going the opposite way, so showing more bold response in the brain for the placebo condition as compared to the control condition. And that was observed right here in the midline in the rostro-anterior cingulate cortex or the ventromedial prefrontal cortex. We were not the first to find this. Predrag Petrovic in the Science paper 2002 found the same area. And also very importantly, Jean Casubieta observed a similar area in a PET study. And this PET study had the advantage over fMRI in our case that he could also show that there are opioid receptors in play here right at this area using 11C carfentanil PET. That was a sort of hint taking up from the seminal papers from the 70s showing an opioid, endogenous opioid involvement in placebo analgesia, sort of a direct hint of where this might happen in the brain using positron emission tomography. We also looked at the connectivity in placebo hypoalgesia. Obviously, we all know that single brain regions do not do behavior. It's the link of activity between those areas. And what we know from the anatomy of the descending pain modulatory pathway, it originates at the anterior cingulate cortex and then bridges into the periaqueductal gray, as you can see here. So this is the first part of the descending modulatory pain system. And that's obviously a prime candidate to be involved in placebo analgesia. And not surprisingly, Predrag Petrovic in 2002 observed connectivity between those two areas using PET. And we were able to look at the same thing and found the same thing here, a connection between the rostro-anterior cingulate and the PAG that was upregulated during placebo analgesia. So stronger coupling between those two areas in case of placebo analgesia. Now, how is placebo analgesia mediated neuropharmacologically? And one of the ideas, obviously, that the brain uses its own endogenous opioids. And this goes back to studies in the 70s, seminal studies, showing that by naloxone, an opioid antagonist can actually block mu-opioid receptors. And by this, it should also be able to block placebo analgesia. And Falk Alpert in the lab, whom you can see here, has actually studied this in a combined pharmacological challenge fMRI study. So we did a very simple placebo paradigm, again, treating skin patches with cream, telling volunteers this is a highly effective cream, generating a high expectation, and then testing them. And as you can see here, in the control group, that's the group that didn't get the naloxone, they just get an IV line of saline going, you find in the control group, feel a thermal pain to be at the level of about 60, but in the placebo group, this dropped down to a level of about 37, although the temperatures applied in both conditions were absolutely identical. So you can see here, this difference is a significant placebo hypoalgesic effect. Now, if we look at the same comparison in the group that received the mu-opiate antagonist, naloxone, you see that this difference is not entirely gone, but not significant anymore and much smaller. So we looked for an interaction, asking whether this difference is bigger than this difference, and this was a significant interaction, indicating that the placebo analgesic effect, at least in part, is mediated by the release and action of endogenous opioids. As I mentioned, we've done this study also in the scanner, and we can observe that this area that I've shown you before in the rostral anterior cingulate cortex shows a strong activation difference, placebo versus control, in the saline group, and that this difference goes away in the group that's treated with naloxone. So basically, again, showing that this activation, as in the PET study, seems to be involved in opioid, endogenous opioid analgesia. We also observed similar responses in areas of the hypothalamus, the periaqueductal gray, and the rostroventromedial medulla. Now, coming back to coupling, we also looked at this in this study, and maybe you remember I told you that there is an increased coupling between the rostral anterior cingulate cortex and the PAG in placebo analgesia, as shown by us, but also by others, for instance, Predrag Petrovic. We looked at this in our pharmacological study, again showing you the saline group first. So you see coupling between those two areas to be stronger in the placebo group as compared to the control group. Now in the naloxone group, this difference was gone. So there was no advantage in connectivity in the naloxone group for the placebo condition, as you see here, that's missing. So there was no difference whatsoever. So telling you that actually it's not only activation in this area, but also the coupling between those two areas that can be blocked by an opioid or mu-opioid antagonist. We then went a step further and asked the question, at what level of the central nervous system does this modulation occur for the first time? And as you all know, from the periphery, nociceptive information hits the central nervous system at the level of the spinal cord. In the case of the arm where we stimulate, it's the cervical spinal cord. And if we do bold neuroimaging in the spinal cord, as we did with Falk Eibert about 10 years ago, we could show an activation pattern in the dorsal horn of the spinal cord. And the amazing thing that we found in this area was that it is actually showing a placebo analgesic effect. So here's the behavioral data from this study. Again, pain applied to a control skin patch is more painful than pain applied to a patch where we applied a specific analgesic cream. But both creams obviously are identical. And again, this difference is the placebo analgesic effect. Now here is what we see in this part of the spinal cord. You see a strong activation for the control condition, but almost no activation for the placebo condition, showing that there is a massive modulation right at that first part of processing in the central nervous system, actually right at the first synapse. Now we then wanted to also look at where in the brain or how placebo can be augmented. And one of the ideas, and that was basically primed by a study by Warber and colleagues, value or price of a treatment could actually boost placebo responses. So if something is more expensive, you think it's more valuable, and you actually think it might help better. So what we did, or Stefan Geuter, when he was a PhD student in the lab did, was devise a study where we had two placebos. One placebo that was deemed cheaper and less effective, and one that was deemed to be more effective and more expensive. And behavior shows a nice effect. The more expensive placebo is more effective than the cheap placebo. It's not shown on the slide, unfortunately. However, we also observed a graded response in the rostral anterior cingulate cortex. So we see again activation for placebo compared to control. This is for the cheap or weak, and this is for the strong. And you can see here is a bigger activation for the strong or expensive placebo in this area as compared to the weak or cheap. At the same time, over the same participants, we also did a valuation task in the scanner where we asked them what they are prepared to pay for the treatment we gave them. They didn't know it was a placebo, so we really asked them, how much money would you basically pay for the cream that we basically gave you and mixed with other items? And the value of the items was, as no surprise, represented in the ventromedial prefrontal cortex. So was the placebo response. And if we put both on top of each other, you can see basically we're talking about very similar areas of valuation and placebo. Now, there's also a line of evidence or research where we can look at how expectation works in pain, which is based on cued pain paradigms. So in this case, we're not generating an experience by conditioning or by any other means, but we're actually showing people cues, and then they will expect a certain intensity of pain. So I briefly talk you through this experiment that also has been performed by Stefan Goether. So people see 3 different visual cues. They're meaningless in a way. So these are abstract visual cues, as you can see here one. And for instance, this cue predicts to 25% a painful stimulus to follow, and in 75% predicts a warm, non-painful stimulus to follow. This thing here would predict that you get 50-50 pain or warm, and this visual cue will tell you it's very likely that you get pain and less likely that you get warm. Now, based on this, we have correctly cued trials and incorrectly cued trials. And that basically means we can not only look at the intensity coding of the stimulus, but also of the expectation and then the violation of expectation that we call a prediction error. So if we sort of think about theoretical outcomes of this experiment, so look at this graph here. So in blue are all the stimuli that are warm and non-painful, and in red are all the stimuli that are painful. So if the different cues have no effect whatsoever, so this is pain cue telling you below, medium, or high, and if the pain cues have no influence whatsoever, you find 2 straight lines here. So whatever is hot will be basically activate hot or rated as very high, and what's basically lower will be low. Now, if prediction or expectation plays a role, we would expect that we get an increased activation or rating, not only based on the intensity, but also based on the expectation or the cue. And if we combine this and this is what we get. So this is basically a difference between hot or painful and warm, and at the same time an increase for the different cues. So you get an expectation effect and a stimulus effect. Now, if you now take the difference between what you predict and what you really get, this is the error, and that's basically shown here in red. So for instance, here, if you think you're getting a warm stimulus, but you get a painful stimulus, that error is big. If you think you get a high intensity stimulus, painful, and you really get a painful stimulus, that error is low. And you can find a combination of all these effects as been shown here. So the first sanity checks of this experiment looked at whether people can dissociate our 2 intensities. And as you can see here, pain was rated much higher than the warm stimulus, so that worked pretty well. Reaction times to responses of their ratings, or actually saying there was a stimulus, was the same for both. But the surprising results come from the skin conductance responses and the pupil responses as shown here. And as you can see here, if I go back one, it's not a simple stimulus coding. So the 2 lines are not just parallel, but it's actually something like this. And what does this mean? It means that in the low case of a pain cue, if you expect low, you find a real difference of hot and warm. However, if you are cued and you expect a high pain to come and you actually get a low pain, this is what you basically see in terms of skin conductance response, and this is for the pain. So you see that by the cue, 2 very different stimuli become to elicit the same response. And the same thing is actually true for the pupil responses. We also did this in functional MRI. And as you can see here, we were mainly interested in the insular cortex. And very interestingly, if you look at the posterior part of the insular cortex, the right hemisphere and the left hemisphere, you find intensity coding. So whatever is hot gets more signal as compared to whatever is only warm. And it's the same in the right and the left hemisphere. However, if you move forward in the insula towards the anterior insula, what you observe is a strong interaction, very similar to what I've shown you in the skin conductance responses. So in the low expectation condition, you get a clear difference between high, pain, and warm. However, if you expect high, there's almost no difference, showing you that there is a strong effect of the cue on the response in this area. And we've conducted an additional experiment using 3 cues and 3 intensities, and basically show in a very similar paradigm exactly the same thing. In the blue coded is the posterior insula here. You show a simple intensity coding, flat lines. More heat or more pain gets more activity, then less pain and even less pain. Then in the anterior part, we see this interaction response, which is in agreement with the prediction error. And in this experiment, we could also reveal a part here in the part between the posterior and the anterior insula coded in yellow that shows simply an expectation effect that we couldn't observe here. Now, in these experiments, the cue and the pain were almost following immediately. So there was a cue and there was a pain. Now, obviously, fMRI is a very slow technology, so you cannot really say what's going on or how is this orchestrated on a fine temporal scale. To actually do this, we have to revert to EEG recordings. And so Andreas Strube, who is a PhD in the lab, has performed a very similar experiment using EEG. And first, we look at the effects of expectation. The plain effect of expectation can be seen around 1.5 to 2 seconds after cue onset in the alpha or beta band. So it's an increase that is proportional to the expectation. So more alpha beta activity for more expectations. And if you do a source reconstruction of this cluster here, you'll find cortical areas, including the anterior insula. Now, if we now look at the same analysis for prediction errors, and now looking at pain onset as a marker, we find changes in gamma power in the gamma band to be associated with prediction errors. And again, if we source reconstruct this into the brain, we'll find activation probable sources in the anterior or posterior insula. And if we draw a schematic of these results, it looks as follows. So this is the cue onset where we cue high or low pain. This is the pain onset. And this is the cluster in the alpha beta band that codes expectation, which is then temporally followed by an absolute prediction error in the gamma band. What I haven't shown you is that we also, if we look at just simply stimulus intensity, we find activity in the gamma band and in lower frequency bands. And as you can see here, they come a little later. So not surprisingly, expectation is first and then followed by prediction error. But let's try to sort of look at this process of integration in a little bit more detail. You remember from the very first slides that this is a very simple model of how placebo might work. You have this treatment expectation, you get a sensory input, and as I said, you just simply meet halfway. However, we would all say that treatment expectation can be different. It can be very reliable and you trust it, so it should have a larger effect as compared to if it's very sort of noisy. And this is actually captured by a sort of finessed model where this precision is taken into account. And very simply, this is exactly what Bayesian integration is all about. It's not taking into account where these peaks are, but also how noisy or variable these are. Just let me briefly talk you through it. Now, on the x-axis here, these are VAS ratings. Color coding is the same. So this is treatment expectation, this is your sensory input. But in case of a simple bar, you now get a distribution. What does this distribution mean? This means, in essence, this volunteer would expect on average that the treatment gets you a pain of 30, but sometimes a little less and sometimes a little more. captured nicely graphically by this distribution. The same for the sensory input. On average, it's 50, but sometimes it's a little bit more. Rarely it's much more, and rarely it's way less. If you now integrate, using Bayesian integration, this distribution with this distribution, this is what you get. It's called a posterior, and that, we argue, would be basically your perception. But now turn to this example, where everything is the same, apart from the precision of your expectation. Here the precision is quite big, because this is a narrow distribution, and here your precision is actually quite broad or bad. That means you're only on the mean, you get 30, but you can also get like 15, which was very unlikely here, or you get 45. So it's a high variability or high variance in statistical terms of your expectation. And now this expectation is not as reliable, so it should not affect your percept as much as in this case. And if we now do a formal Bayesian integration of the blue distribution and the red, percept is in green. As you notice, if you compare the two, this percept is much closer to your sensory input and much further away from your treatment expectation. Whereas here, your treatment expectation pulls your percept much harder because it's more precise. And this idea, we wanted to test empirically in a study. And this is the study that we've conducted, or it has been conducted mainly by Avina Kral, who is in Boston. And we're very happy for her to be with you guys. Now, Avina did the following. She did a placebo analgesia paradigm where the conditioning procedure was different for two groups. And it was different that we conditioned with a main effect of 30 in the placebo condition and 70 in the control condition. But the conditioning, that means we basically supposedly treated people with TENS as a placebo, but we actually reduced the intensity of the pain, the thermode, to a lower level, basically making them experience that the TENS treatment actually works. In one case, the orange case here, we basically lowered the temperature constantly to 44.5 degrees in one case, if that's 30 VAS. However, in another case where we wanted to have the experience more variable or less precise, we actually oscillated around this mean and sometimes used 40.1, then sometimes 45 point something, low, high. And as you can see, the blue curve has a high variance. So they learned actually that this, although average 30, is not as reliable as in the constant case of 30. So the idea was that a high precision, that's this case here, the orange case, should get you a stronger placebo effect. And to cut a long story short, this was exactly what we observed. This is the placebo analgesic effect, which is significantly bigger in the group that was conditioned constantly, that has the more precise expectation as compared to the other group. Now, if we now look at individual subjects and how this works, we'll basically do a formal Bayesian integration in a single subject. So these are the ratings of one subject during treatment expectation. So this is actually the data points. And if you try to fit a Gaussian curve to that, that's what it looks like. Now, let's have a look at the perceived sensory input of that volunteer. It's the curves in red. So you see the sensory input seems to be pretty noisy. The treatment expectation seems to be pretty precise. Let's look at another volunteer. Here it's different. These are the ratings for expectation. This is pretty imprecise or variable, whereas the perceived sensory input is pretty precise. If we now do formal Bayesian integration of the two curves in both subjects, this is what we get in this subject. Expectation precise, that means the percept should be close to the blue curve, whereas in the other guy, the sensory input is more precise, expectation is less precise, the green curve moves more towards the perceived sensory input. And this is exactly what we observed in these two volunteers. These are the best volunteers, sort of just to exemplify the case, but we did this in the whole group of volunteers and basically compared this Bayesian integration model to a null model, and wherever these blue bars are higher than the red bars, this integration model wins. And if we look at this over the whole group, the model posterior probability of this placebo-Bayesian integration model is much higher than the control model. Now, as I've mentioned, the difference between your sensory input and your perception is the placebo effect. And the question now is this correlated with some of the metrics that we basically observe in this paradigm? And yes, it is. The attraction weight is basically a metric of how much this distribution of the percept is driven towards your expectation or prior. And that's actually correlated positively, as you would expect, with the observed placebo analgesic effect in the whole group. But at the same time, we also look at the representation of this in fMRI. And we actually look at the representation of this attraction weight, or in other words, how much it actually is pulled towards your expectation. And that was represented in the periaqueductal gray. Now, we're leaving integration, we're leaving placebo analgesia, and we're coming to nocebo analgesia. And this is my favorite example of nocebo analgesia. It happened in Hamburg about 6 years ago at a high school graduation prank that was played by the sort of 18-year-old high school graduates on their younger kids. They brought, as you can see here, drinks to school, soft drinks, and let the kids drink the soft drinks. And by a rumor that was spread, it was told that these drinks are actually spiked with vodka. You can imagine parents going crazy, rescue or emergency services on scene. 5th and 6th graders went to hospital in large amounts, 32 kids hospitalized. You can see actually kids here with IV lines running around. The forensic department of the university hospital took over, blood samples were drawn, and guess what? Not even a trace of alcohol was found in these kids. These kids were all drunk. They were swaying, they were running around like drunken sailors. So by expecting to get drunk by spiked drinks, which were not spiked at all, you get severe intoxication of alcohol, at least the symptoms of it, and very concerned parents. Now, nocebo analgesia also happens in pain. And this is a very complicated study that was performed by Alex Tinnerman when she was a PhD student in the lab. And we not only investigated nocebo hyperalgesia, but at the same time looked at the effects of value. For this purpose, she actually designed 2 drugs. These drugs don't exist. This is imotadil from a company called Lenny Pharma, and this is Solestan cream by whatever Clada Pharma. In Germany, this looks like a generic drug, this looks like an expensive drug. And that was our purpose, to actually design drugs that look more expensive as compared to this one. By the way, imotadil, which actually supposedly works against neurodermatitis, does not exist, but volunteers didn't know this. Now, the first thing that we basically checked is, would people actually, this is an independent sample, would people actually be prepared to pay more money for our blue expensive cream? And indeed, they on average would pay 12 euros for the blue cream and only 10 euros for the orange cream. Interestingly, this was mirrored by an effect or difference in the nocebo effect between nocebo and control. So the effect, the expensive cream had a much more pronounced nocebo hyperalgesic effect as compared to the cheap cream. And interestingly, this did not decay as a function of time. So these are individual trials and test run. So you see that people rate the cheap nocebo as less side effecty as compared to the expensive treatment. So a clear indication that value again modulates expectation effects, in this case nocebo. We observed nocebo-related effects in the periaqueductal gray. So as you can see here, more bold response for nocebo as compared to control, and this difference being bigger for the expensive condition as compared to the cheap condition. This was also observed in the spinal cord, more activation in the hyperalgesic nocebo condition as compared to the control condition, and again, an interaction, bigger effect for the expensive drug as compared to the cheap drug. And that's very similar to a previous study that was done by Stefan Goethe in the lab, also looking at spinal responses to nocebo hyperalgesia, showing an increased bold effect in the spinal cord for nocebo as compared to control condition. But very interestingly, we also observed activation in the rostro-anterior cingulate cortex. On average, this area showed less activation for the expensive nocebo condition as compared to the cheap nocebo condition. And remember, this was the most effective. So this actually gives you the biggest nocebo effect. So what Alexandra then did is actually pooled over both parts of the experiment and just simply plotted the activation in this area on the y-axis against the behavioral nocebo effect in this volunteer. And as you can see here, it's a negative slope. That means you get less bold activity for more nocebo effect. So it's exactly the opposite as we observe in the placebo effect, and I'll come back to this. So if you take this experiment, correlation of nocebo hyperalgesia with activity in the rostro-anterior cingulate cortex, as I've said, less activity for more nocebo. If you then go back to the experiment I've showed you by Stefan Goethe, showing you more activity in the rostro-anterior cingulate cortex for strong or expensive placebo and less activation for weak placebo, let's put these two sort of results on this curve. So the weak placebo basically gives you little activation, and the strong placebo gives you higher activation. So in theory, all these points could lie on a single line from nocebo to placebo. And one of the ideas that we have is that this might support the hypothesis that the VMPFC or rostro-anterior cingulate cortex just simply mediates the value of treatment. And obviously, a placebo treatment that's going to help you has a higher value as compared to a nocebo treatment that is going to harm you. This is also in agreement, obviously, with other areas, with other results from evaluation studies, for instance, in terms of money or food. Now, I've talked about nocebo hyperalgesia and about value in the rostro-anterior cingulate cortex. Is that something specific for pain, or is that maybe also something that crosses domain borders and can be observed in other nocebo effects? And that's one of the reasons why we actually turned away from pain and actually entered the realm of respiratory medicine. And this is just to show you a very prominent example of the role of expectations in respiration is the famous study by Ted Kapchuk's group by Wechsler in the New England Journal, showing the effects of positive treatment expectations in asthma. And to cut a long story short is they observed for a beta-2 mimetic drug, a beta-2 agonist, a placebo and sham acupuncture, very effective responses as compared to no intervention if it comes to the rating of subjective improvement. They also measured airflow differences, and here you can see albuterol, beta-2, does a perfect job, whereas placebo, sham acupuncture, and no intervention control are at the same level. So a very interesting or very simple dissociation. Subjective measures are affected by placebo, whereas the airflow differences are not. So people feel better, but their airway restrictions or resistance has not changed. Now, we designed an experiment in respiration looking at exactly the opposite. We actually wanted to investigate nocebo effects in respiration. And this is based on the ideas that basically were studied in the 70s and 80s, where people argued and showed some evidence that just the exposure of an allergen as a picture, like showing people a haystack, can actually trigger asthma symptoms. So basically a nocebo or expectation effect. So this was a study that's being conducted in the lab by Elke Flemings, and this works as follows. It's a very complicated design, so bear with me for the details. The volunteer was lying on his or her back wearing a PEEP mask. So we're not in COVID on the ICU, but very similar. Positive and expiratory mask. So it's a very tight mask, and you can only breathe through this little hole here. And you have a standard piece here with an inspiratory part and an expiratory part. So whatever people breathe in, breathe out, the air comes in through here and goes out through here. Now, importantly, in this part of the system, we could introduce respiratory loads, like a resistance, which were basically sieves. So if you think about this as breathing through your mask in COVID times, this is a respiratory load. So it's more difficult to breathe through a mask that has a high density mesh as compared to whatever a little sieve. Again, we basically, using a pneumotachograph, measured respiratory flow and expiratory CO2 levels, and also with a very fancy occluder technique, could estimate the airway resistance in all our volunteers. On top of all that complicated equipment that was all going into the MRI scanner, we also had an olfactometer attached where we can present different odors to the volunteers, again, also through the mask. We used clean air as the neutral condition and 2 alcohols as the odors. These are aromatic alcohols. They basically smell nice and are clearly distinguishable. So what did we do? The experiment was divided in an experience phase that we can also call a conditioning phase, and an expectation phase that we usually call a test phase. So what does a trial look like in the experience phase? You basically get a visual cue what to expect. The drug that we told people will actually close your airways and make it hard to breathe, or the control. These are the 2 alcohols. You then get the smell of either this one alcohol or the other alcohol. And then during a part of the expiration, we introduced, without volunteers knowing, that resistance into their airways. In one case, a 0.81 kilopascal resistance, or in the other condition, the control condition, no load. So they basically learned that when smelling this alcohol, breathing is getting harder. And that's how we condition them, that they learned this, oh, this alcohol, whenever I breathe this, this means my airways constrict. Then during the test condition, we played the same alcohols, as you can see here, but now the resistances were identical and of a medium intensity. So here are the results of the study. In very simple terms, we found very similar things to Ted Kapchuk's group. The dyspnea rating was heavily affected by the experience, but also by the expectation. So this is actually the condition where they really were breathing against the 0.8 load. This is when they were breathing freely. Now in the expectation group, where both loads were identical, we still found a difference. When they expect a high load and expect a low load, subjectively they rated their dyspnea to be different. However, end expiratory CO2, airway resistance, and ventilation, all the same. So in fMRI that I want to show you briefly, first we looked at the experience phase. So what do we expect here? Where do we find areas in the brain that show more activity if you're working against the high load, so you're breathing harder? And that was, as shown in previous results, found in the anterior insular cortex. So you see here during experience, for the dyspnea condition where you breathe against this resistance as compared to the normal breathing, a strong activation of the anterior insula. And that's here the time course, and we're looking at this part of the curve. Now, interestingly, we observed a similar pattern in the periaqueductal gray. We are now lower in the periaqueductal gray as we are in the more respiratory section, in the pain section of the PAG, and again observed higher activation for breathing against a resistive load as compared to control. But importantly, a similar effect was observed during the expectation condition. And remember, the resistance of these 2 conditions was identical. So the same amount of dyspnea actually for these 2 conditions. However, subjectively, this is mirrored by activation in the PAG. And now finally, and that's very close to the end of the talk, is do we find something specific to the expectation phase? And yes, we do. We find activation in the rostroanterior cingulate cortex, as in the pain study that I've shown you by Alexandra Timmerman. And again, we find the opposite to placebo. We find an increased bolt signal during the control condition that's actually more pleasant because it's not as hard to breathe, you think, as compared to the expect dyspnea condition. But again, keep in mind that these two are identical, the same midway loads. So here you can see a coding of this area of the load during the expectation condition, which we would say is an agreement with, again, coding of the value. In this case, it's not pain, but of respiration. So I'm coming to the last slide, time's up. I hope I've shown you that placebo analgesia or hypoalgesia is mediated by endogenous opioids, that this includes the rostroanterior cingulate cortex and the PAG, and there's also modulation at the spinal cord level. I've then shown you that the RACC VNPFC system seems to be related to placebo and nocebo with a signed response, and that could actually represent the value of treatment. But this is not only the case, as I've shown you in the last study, for pain, but seems to be the case also in respiration. And finally, I've shown you a possible mechanism of how expectation and the precision of expectation is integrated with sensory information. And that's it, and I thank you for your attention, and I'm happy to take questions.
Thank you, Christian. That was remarkable, tremendously exciting. We have several questions, and one comes from Thomas Rosal, and he asks, vitamin D receptors are found in the anterior cingulate. How does vitamin D deficiency affect the placebo-nocebo effect?
You mean vitamin D?
Yes.
Yeah, to be honest, I don't know much about vitamin D and vitamin D receptors in the brain, so I cannot help you here.
Have people looked at other drugs that beyond naloxone that might perturb the effects that you're seeing?
Yeah, well, as you've remembered, there was basically a reduction of the placebo response by naloxone, but it was not totally abolished. Howard Fields, these seminal studies that Howard Fields conducted in the 70s, they basically at the time showed a full abolishment of placebo responses. In our case, there was something left. Now, there's some interesting literature and actually some evidence mounting, although there's little controversy at the moment, that the endocannabinoid system, so cannabinoids might also play a role because they're very similar to opioids in terms of being sort of mainly inhibitory neurotransmitters at the GABAergic interneurons. So cannabinoids are possibly related. The problem is here we don't have a drug that is as nice as naloxone and can be used in the human, because the only antagonist is basically taken from the market because of increased rates of suicide. Rimonabant it was.
Yeah. So is your assumption that this is all working through the opioid receptor? Like, have you looked at other neurotransmitters that might also influence what you see?
Well, it's probably not all about the opioidergic system. Ulrike Bingel has done some studies looking at the dopaminergic system, and actually it was a negative result. So basically modulating the dopaminergic system with a strong antagonist, haloperidol, showed no differences. But serotonin plays a very important role in the descending pain modulatory system, and that's some other candidate that might play a role. And don't forget that all the neurotransmitters heavily interact. The opioids basically don't do it all by themselves.
Right. Here's a question from Chandana Kodiwara. Very interesting how expectation can affect the experience. Is perception always higher than expectation?
This is, well, only in the case of placebo. I should have shown you the same thing in nocebo. Actually, the idea is if you create an expectation that is lower than your perception, then you're biasing people towards a placebo effect. if your expectation is much higher than what I give you, this is what we actually use for nocebo hyperalgesia. So we tell you this drug will have basically an augmenting effect on pain, so expect high pain, and we then actually give you low pain. So in this case, the expectation will sit on the higher side of the sensory input.
I was wondering, kind of building on that, in your heat experiments, looking at the insula, if you had given people a very, very cold experience, which they're totally not expecting, they've not had, and obviously isn't necessarily harmful, what do you think would have happened?
What do you mean with cold experience?
So they're expecting, you know, something in the heat to warm to hot region, but you give them something in the like ice water experience, and they're definitely not expecting that. Like, what would happen? Do you think they would perceive it as heat?
That's an interesting thing, and it's obviously one of the things in the Bayesian integration ideas. If you expect warm and you get heat, you might integrate that because it might be close enough to say, oh, I expect less temperature that I get. However, if you would basically expect heat and that get cold, you would probably basically reject the whole model because it's so far away from what you predicted. You would say, what are they doing with me? This is not an experiment anymore. It's fake. So
Right.
they're trying to fake it here.
Interesting, yeah. Let's see. There's a question about the sham acupuncture performed in the airflow studies. How was that performed? And is
no, that was a misunderstanding. In our case, in the respiratory study, there was the treatment was actually the hysterinol, the alcohols. So we basically told them that they were inhaling a gas that can actually make their airways constrict. So there was no acupuncture there. So the treatment was supposedly an inhalation of a gas that led to a constriction of airways. Obviously, it doesn't. The alcohols didn't do anything with the respiratory system.
Here's a question from Tor. Hi, Tor. Hi, Christian. Wonderful talk. And I love the respiratory study, among others. Is there a strong expectation effect on the spinal cord? Where does the input come from that drives prediction errors? Or is spinal modulation less complete or perhaps context selective, i.e., it happens sometimes, not all the time?
Yeah, that's a very interesting question. And to our big surprise, and if you basically remember the slide I've shown you from Falk study in 2009, the reduction of inputs that we observed in the spinal cord was almost bigger as we observe it, for instance, in S2. And obviously, Tor's question aims at the sort of direction of how is it possible that the signals already reduced so much at the spinal cord level and then still can generate a prediction error. I think the answer here is that this voxel that we show is actually the voxel that shows the strongest placebo effect, meaning the biggest difference between placebo and control. There are other voxels, and it's in the supplement of the paper, that actually show pain responses that basically go all the way up to the cortex. So my idea here is that the modulation of placebo in the spinal cord is not a direct effect, doesn't happen at the spinal cord. Basically, information goes all the way up to the cortex, and then by the descending inhibitory or pain modulatory system goes all the way down again to the spinal cord via the PAG and the medulla.
Wow. Here's a question from Carmen Bango. How can we apply theories of prediction, expectation, and the role of precision to a chronic pain model?
Yeah, that's an interesting thing. Is the chronic pain. Now, expectations play an important role in chronic pain because it's a sort of a vicious circle. You have pain, you expect more pain, and therefore your expectations of pain might actually get more and more precise. And as I've shown you, a more precise expectation will drive your percept much harder towards this than towards the other. So in a way, it's a nocebo effect that plays a role, an expectation effect that's more likely a nocebo type effect in chronic pain. And in a certain way, what you would have to do is, try to destroy the precision of the expectation of more pain. So in this case, in placebo, you want the expectation to be as precise as possible. In this case, you want to have the patient's expectation that the pain will continue to be less and less precise. So, but that's obviously, I think, one of the sort of mechanisms how psychotherapy in chronic pain actually works, by trying to break this vicious circle and making the expectations of the patient that pain will continue, sort of actually destroy the expectation to more pain, or this nocebo effect.
That's really interesting. Can you kind of cross over between your studies and chronic pain? So, for instance, you use the cream in your conditioning model, and then you give them the cream to take home for their chronic pain, having been taught.
Yeah, I would say at the moment, this is sort of, we're looking at acute things here. So the longest painful stimulator I've shown you today was probably 8 seconds. And that's far away from the sort of ongoing pain in chronic pain patients. We've changed gear in the lab and basically have started to look at longer painful stimulation of 2 minutes. And I've actually just got a grant where we actually look exactly on very long-lasting pain in healthy volunteers and also in chronic pain patients, where we basically not look at very simple placebo-nocebo studies, but where we actually look at the role of expectation and how we can actually, as I've said in the previous comment, how we can actually make the expectation that pain is followed by more pain less precise, and therefore basically downgrade its impact.
Wow. So I think we have time for 2 more questions. Here's a question from Darshan Mehta. Inevitably, critics of homeopathy will claim that the field is simply a ploy on expectation and placebo effects. How have you come to think of this as a scientist? How does your body of work seem to point? What does your body of work seem to point towards?
It's a very simple answer. There's no real evidence that homeopathy does anything physically with your body. However, we have a lot of good evidence that expectation does a lot to your brain and your body. And at the moment, I think the best guess of homeopathy is that it's a pure expectation effect.
And from Raymond Lloyd, would vagus nerve stimulation secreting acetylcholine affect pain, respiration, perception?
It definitely will. And this is a very interesting field of study that we haven't looked into yet. But the autonomic nervous system plays an important role in the regulation of bronchial constriction, as you all know. So vagus actually makes bronchial constriction, and it would be extremely interesting to study this. We are at the moment looking at the sort of brainstem centers of the sympathetic and parasympathetic nervous system to actually look at the influence of both systems on placebo-nocebo responses. And yeah, I can't tell you much about this, but this is some very exciting things to come.
Wow, I'm gonna keep going with, there's some great questions coming. They're just coming and it's so exciting. So I'm gonna keep going till, somebody rings a bell. Here's a question from Kristen Corman. Is there any relation between placebo mediation and visual constraint of touch, visual capture, during disorienting circumstances?
I'm not an expert in this area. Can't say much to that, sorry.
It's an interesting question. Yeah, I'd love to discuss that at some point. From Peter Wayne, given the critical roles of expectation and consistency of information, are there lessons relevant to healthcare providers? Example, massage therapists, mind-body instructors, and physicians?
Yeah, absolutely. This is what I was basically pointing out earlier. Now, if you have a certain treatment or make a certain promise of a treatment and create an expectation, and if that expectation is extremely far away from being believable by the patient, or in our integration case, the 2 distributions are so far away that no Bayesian integration can put them together, the patient will obviously reject the model meaning that there is a real treatment going on, and will basically revert to another model, and that model simply being, I'm not treated here, it's all sham.
Wow. And okay, here's our last question from Giulio Ongaro. Thank you for your talk. What do you make of the fact that words and drugs can engage the same biochemical pathways as per the Benedetti studies? Do you see it as a further proof of Bayesian integration in the brain?
Did I understand correctly? Words and drugs?
Yes, words and drugs.
Yeah, this is beautiful, because what that means is it's actually words and drugs work on the nociceptive system by one organ, and that's the brain. And that's all the miracle is there. So it's basically a word might be something that you think is sort of very abstract, but when it comes to neuronal patterns, it's extremely concrete of neurons firing. A drug will change the brain, and that's where the integration happens. Yeah. So there's no magic about words. Words are just stimuli that the brain will basically process, and they can then help by very simple biological, no, not simple, but a complex biological process change your pain perception.
Yeah, and so the last question, again from Giulio. Your presentation and empirical studies mostly refer to contexts of acute pain, which show that precision certainty correlate with the magnitude of placebo effects. Yet there are studies on chronic conditions, example Parkinson's, heart disease, showing that uncertainty about receiving an effective treatment leads to a higher efficacy than certainty about receiving it. What do you make of these findings, and how can the Bayesian paradigm accommodate them?
Yeah, I think that this refers to the same what I've mentioned before. If the variability is so big that you basically cannot integrate your expectation with the outcome anymore, you would basically reject the model. And that can lead, in this case, although you would think that a sort of more variability could help here, actually to rejection of the model, and therefore being more harmful than helpful.
Wow. Well, Christian, thank you for your great words. And I guess, as Julia pointed out, words are drugs. So thank you for a wonderful, wonderful session. And I wish you much safety there in Germany, and everybody else on the talk. Thank you so much for joining us today.
My pleasure. Thanks a lot for having me.
Yeah, and just one notice that next month, 2021, I guess, I'm not sure. It looks like we have our a 2021 schedule for the Grand Rounds that's going to be posted online shortly. And you can see that at oshacenter.org later this month. Thank you, everybody. Have a great day. Thanks, Christian. Take care.